everyone. Welcome to the second Policy Roundtable meeting convened by Rare Cancers Australia and Australian Genomics, exploring the importance of the application of genomics in cancer control. At the last roundtable meeting in Canberra, we uncovered a lot of the principles and the needs perceived by the group in terms of application of genomics for cancer care. And today we're going to be delving more into some of the implementation considerations, health economics, the evidence requirements, and also the utility of genomics to help guide therapies. So I'm very excited to be joined by a range of excellent speakers to explore these topics and then delve into them in a little more detail with the group that are coming together today. So join us for the conversation. Hello everyone. It's a real pleasure to be here at the second Genomic Policy Roundtable meeting hosted by Rare Cancers Australia and Australian Genomics. Very excited to have Ilias Granithis here with me today. And we're going to have a few questions with Ilias just to set the scene for the discussions that we'll be having in both this Policy Roundtable meeting and the next one, which will be convened next month in Sydney. So, Ilias, we know that genomic testing and interventions are available for Australians with cancer, but not widely available or affordable. So there's general consensus about the need for greater access to genomic-led cancer control. And your research is really important in this area. Can you share a bit about your work exploring the value, the cost effectiveness, and, you know, importantly, sort of the cost benefit of genomic-led cancer control?
Thanks, Steve. So I'm Associate Professor of Health Economics at the University of Melbourne, and over the past 7 years, I've been leading the Health Economics program for Australian Genomics. So health economics is about helping decision makers to make informed decisions about how to best allocate resources, the limited healthcare resources that we have in order to maximize the health in society. So my research has really focused on understanding and measuring the value of genomic medicine and the value for money. And when we talk about sort of value of genomic medicine, we talk about the outcomes that are important to patients and families. And our research shows that sort of genomic medicine generates a broad range of outcomes that are important to people, and that we really need to look at them holistically, not just in isolation, because that just really sort of runs the risk of misinforming policy decisions. We also look at the value for money, and the idea here is that we look whether that sort of value, whether the cost of genomic medicine is justified on the basis on the value that's generating for patients and families, and also potentially reductions in downstream costs to the healthcare system. And
you also led the work of Cancer Australia in evaluating, you know, to inform the national framework for genomics in cancer control. Can you share any insights from your work, in that body of work?
We were privileged to run the health economics review to inform the evidence review for the development of the national framework for genomics in cancer control. To me, the first surprising thing that I've sort of noticed is that Australia has really contributed about 3% of the overall evidence in that space, which is less than we should expect, and that sort of highlights the need for further research. But I'm also delighted that sort of some of that research is actually now ongoing and is going to inform policy. There's a lot of exciting work that is now going through, not only from my team, but other teams as well in Australia. So the review highlights that there seems to be convergence in findings for certain cancers, both at sort of the diagnostic, early sort of diagnosis and prevention of cancer, particularly for breast and prostate and colorectal and ovarian cancers. And also later on, when there is treatment, there is sort of testing to inform the treatment choices for certain cancers. And again, there is some convergence across different countries that say that that genomic medicine is cost effective. for example, have breast cancer, non-small cell lung cancer. So there is convergence in some evidence, but there is a big area of research that needs to be done across the other cancers.
And so structurally, so today in today's roundtable, we'll be exploring issues of implementation, and an area that I'm very interested in is, having that sort of learning health system where adequate evidence is collected as part of routine care to then inform future policy decisions. Can you speak to that sort of concept a bit and implications perhaps for implementation?
Yeah, I mean, this is exactly where we should be going to. I think this is really important to start utilizing real-world data and informing those evaluations and implementation decisions. That's the direction we should be going. I think at the moment we do what we can with the data that we have and the methods that we have. But we should be heading towards the use of real-world data. We should also start expanding our methods ourselves as well. So when we can incorporate equity considerations more explicitly, incorporate patient preferences more explicitly, incorporate the system's capacity more explicitly. So we need that evidence base to start expanding and using those real-world data to inform.
At the last roundtable, Louise Lyons was presenting the perspective from access for genomic and cancer control for Indigenous peoples. And I know this is an area that you're very interested in as well, the health economic implications of various health interventions for Aboriginal and Torres Strait Islander people.
So yes, this is an important area of work. We need to ensure that the data from Indigenous communities, but also other culturally, linguistically diverse communities are reflected and captured, and we can really understand the distributional impacts that genomic medicine can have for those communities. This is an important area of research for us, and I'm excited to see that growing.
You're also very well networked internationally in the context of health economics research. What can we look to, where can we look to internationally that is particularly exploring issues of the use of genomics in cancer control well? And, how can we perhaps, stand on the shoulders of giants in that context?
Yeah, there's a lot of exciting work happening in Canada, for example, and not only from the Indigenous genomics aspect as well, but also in terms of those real-world data and how this should be used to inform evaluation implementation. I think this is something where we can really work with the Canadian teams and help us develop those approaches and ideas further.
Great. Elias, thank you so much.
Sounds good. Awesome. Thank you.
So I'm joined by Associate Professor Rachel Conyers, who will be speaking with us today about the role of pharmacogenomics in cancer control. So, Rachel, lovely to have you.
Thanks for having me.
So maybe initially let's just have an exploration of the role of pharmacogenomics in cancer care. If you'd like to introduce the topic.
Yeah, sure. So probably the best way to think about pharmacogenomics is that our genome, our genes, impact how we handle medications. So I think we all know about how some people say that Panadol works for them and other people say it doesn't work for me. That's nothing more than pharmacogenes controlling how we metabolize some medications. And there are big groups internationally have worked really hard over the years to work out which enzymes in your liver metabolize things quickly or metabolize things slowly, and written guidelines about how we can interpret those genetic changes to help prescribing for practitioners.
So, and you mentioned this international body of evidence. Where can we learn from? Which nation is doing this well in terms of applying pharmacogenomics to cancer care?
Yeah, it's a really good question. So in terms of the international leaders, there's really three big groups. There's a French group, There's the CPIC group, which is the Clinical Pharmacogenomics Implementation Consortium, which was built out of St Jude's and Stanford, but really has contributors from international, including from Australia. And also the Dutch UPGX group. All of them have guidelines. The guidelines are now harmonised. So in terms of getting the evidence is really available. The problem with pharmacogenomics is the implementation, and why aren't practitioners utilising these guidelines and doing the tests and then prescribing according to the guidelines to try and reduce adverse drug reactions for their patients, or also importantly inefficacy.
It's curious that, as we're moving into this era of, molecularly informed targeted therapies, that there hasn't been the implementation and uptake of pharmacogenomics in cancer care to the extent you'd imagine. I mean, given the toxicity of some of these, therapies, guiding that through pharmacogenomics would seem like a no-brainer.
Yeah, I agree. I mean, you're talking to the, preaching to the converted. But, our team has spent a lot of time thinking about this, and one of our national studies is kind of looking into the implementation question. One thing you might think, well, maybe that it's not being implemented because the evidence isn't there. Does it really reduce adverse drug reactions? But most recently, just last year in Lancet, Professor Swen from the Dutch UPGX group published in Lancet a very large adult study proving that in community-based prescribing for adult medications that are used a lot, like cholesterol-lowering agents or antiplatelet agents that you use if you've had a heart attack, that did reduce adverse drug reactions. So I guess in at least in the adult world that has been proven. The cost efficacy hasn't yet been proven, so maybe there's a question there to be answered, and the reduction in adverse drug reactions in children outside of TPMT prescribing hasn't been proven. But I don't think that's the whole picture. Like, the actual international evidence guidelines are evidence-based and high-level evidence. So I think it's more about, that trickier end of, do we have all the stakeholders truly engaged? One thing we've found with our national study is that there's a huge education piece in it, and also some lack of understanding, or maybe lack of direction around whose job is this? Is this the role of the pharmacist, or is it the role of the general practitioner? In cancer care, is it the role of the oncologist? How does this come together, and who do we need to educate?
So in our last roundtable meeting, we asked attendees about their sort of vision for, where would we be in 5 years, in 10 years, in terms of Australians being able to access genomically informed cancer care. Do you have thoughts along those lines? Where would you like to see us in 5 or 10 years?
Yeah, it's a really good question. I would like us to be using all the genomic data we have with the evidence we have to minimise drug inefficacy and drug toxicity. In children, 90% of our patients are survivors, but 60 to 70% of them are left with serious health issues that impact their quality of life. That's a result of their cancer therapies. And so there are huge gains to be made there. It would be great if everybody had preemptive pharmacogenomic testing, so that from the moment we start treating them, we can optimise all the medications, and not just the ones that are getting rid of the cancer, making sure that they have efficacy from their anti-vomit medication, that they're not sitting there in pain because they're metabolising off all of the analgesics. So it would be great if it was standard of care across the sort of whole of cancer therapy space, And the other thing I'd really wish for is that we had a targeted workforce that was acting on the PGX testing, whether that is our pharmacists like it is overseas. It's very much pharmacist driven. And from a quality perspective, having a process by which, as those international recommendations be updated and new genes are found, that is automatically integrated into the system and people's records are automatically updated so that, you know, it's not a one test in time, it's an ongoing kind of perpetual screening.
I think too, you know, in this era that we're exploring the feasibility of national screening programs, you know, for adult cardiovascular risk, cancer risk, reproductive carrier screening, there's great opportunity to ensure that we include pharmacogenomics as part of those programs to ensure this information is available upfront, prospectively.
Yeah, absolutely. And you can already think of certain groups that will be more at risk. So, you know, those patients who have polypharmacy, much more common in adults, but certainly there are many children who have chronic health conditions who would benefit from pharmacogenomic testing. I mean, certainly we know how prevalent mental health issues are. Many of the antidepressants have pharmacogenomic indications for prescribing. And then the other big group that we have seen a little bit of outside of cancer care in our study is anti-epileptics. And it's a small group in paediatrics, but definitely a very important group that utilise some of those medications as well. So yeah, you can immediately see, I mean, some days I think, well, what's the argument on why not? You know?
I think we have to build that case for government too. I mean, it's, part of it is the counterfactual, you know, and adverse drug reactions. When you look at the economic cost on the system, it's appalling. So, yeah, I think the case can certainly be made.
Yeah.
Well, thanks very much, Rachel. Lovely to chat and look forward to your presentation later. So I'm now joined by Professor Claire Scott. Claire, thank you for joining us.
Great pleasure to be here. Thank you for asking me.
So, you know, in the context of these discussions where we're exploring the application of genomic interventions in cancer care, this is an area that you've been, you know, really sort of leading for many years. How have you seen patient outcomes and journeys shift with the application of genetics and genomics to cancer care?
Look, thanks for that question, because I think the patients are really the central piece in this. 5 years or more ago, we had very little access to testing. There was very little government testing. Programs such as Omico had some restrictions. So I work in gynae and in rare gynae, and in rare gynecological cancers, we really had to initiate our own programs for testing. We were interested in looking at some larger testing like whole genome sequencing rather than panel testing, because we knew panel testing was being done well. And so we were fortunate at that time to be funded to really be able to test any patient who didn't fit into another program. So the problem at that point was that we found that we were testing patients too late. And in fact, it only took 13 patients for us to be able to prove that. And then after that, we changed it in our own centre and we were able to bring these patients in at diagnosis. And that was because we got the clinicians online by distributing some early data, preliminary data. So once that happened, we had a much better opportunity to get the results back, which does take some time and certainly did in those days, and make decisions for patients at a more clinically relevant time. It's amazing how if you don't start at the very beginning, you lose precious time. We know for many patients with a rare cancer, they might have a first-line therapy that's recommended, which may be vaguely related to their tumour type, but they very rarely have a proven second-line therapy. So if you have the result at the time when second-line therapy is being considered, you might be able to access it. So one of the problems, even more so in those days, was access to the right drugs. if you think with whole genome sequencing that you're looking across a whole range of pathways, in any tumour stream, you're only going to have access to the drugs that are thought to be relevant for that tumour stream and not to the other drugs. I think what's changed is now that we've got really broad access to panel testing, mostly for most patients, panel testing is sufficient. There'll always be some patients who need more, who might benefit from whole exome or even whole genome if there are recombinations, or unknown fusions that you want to look at. But drug access has improved during that time, particularly through the work of OMICO and other similar, umbrella or basket studies. And for patients with rare cancers, we're really dependent on those larger studies to have drugs available. One problem is that there are always contraindications to patients going on trials, and often our patients might have those contraindications. For example, brain metastases. Some trials don't even allow them, even if they're controlled. So I think that there's some examples, and patients really struggle, go to enormous lengths to try to access drugs, and it is such a pity that they have to do that.
So that's really extraordinary that after 13 patients, there was sufficient evidence to change, to really pivot and change implementation locally. Can you speak to your reflections on the pace of implementation of genomics in cancer care nationally?
So in terms of implementation, it was clearly a lot easier to do it locally. We had some results, we could inform our local clinicians, we got great buy-in from the surgeons and the medical oncologists, and from the people in between, the staff members in between that are needed to actually make it all happen. So that means accessing the right sample, getting the right clinical information, feeding back the information to clinicians and making sure that they understood it. Nationally, we have a much larger scale problem to deal with. Firstly, we really do need to have government-funded testing in order for these processes to be streamlined. And we have some examples of that with ovarian cancer, for example, where certain tests became available, federally funded, leading to drug. And that meant that all the clinicians came on side about it really nationally. But we did have a lot of work to do, not only with our National Clinical Trials Group, ANSCOG, but also with the various pharma companies involved, and other local networking to educate doctors and staff so that everyone understood what was required. So I think that implementation, once there is government access to testing, let alone government access to the right drugs, those two things really go together. That's a huge driver. I guess because we've still got a lack of both of those things, implementation has been done by researchers. And whilst I think that's been an excellent effort, it's still not going to be anywhere close to what we need.
And we need that active pathway to translation, where it's not sequential research efforts delivering what should be clinical care.
A really great example of that, again, for probably any tumour type, is that patients and their precious samples will often undergo screening for trial after trial after trial for multiple different purposes. And often that is an ad hoc one-by-one process. And that is just so inefficient. It uses up, really special tissue. Every time you cut, you waste tissue. So it's so much better for a tumour stream to design, the testing a patient's likely to need within the next 2 to 3 years, and do it all at the beginning, not only so they can get the best shot first. We know the first and second treatments are the most important in many ways. There are game changers later on sometimes, particularly for match therapies, but for most patients that's what we would want. So to be organised about that really can make the difference between life and death, and I could give examples of that. So we work so hard at having the right plan for each patient's journey, and that usually follows in a particular tumour stream for a particular tumour type, and it's multidisciplinary and involves a whole lot of input. We need the whole genomic part of that to be implemented in that plan. And for various tumour types, we can see that creeping in for certain examples. Breast cancer, I'm sure, would be a great example of that. But for many of the patients that we as rare cancer doctors see, it's just so far off.
So Claire, can you tell us a bit about the Australian Rare Cancer Portal, please?
Thank you, I'd be delighted. So the Australian Rare Cancer Portal was designed specifically because patients with rare cancers would receive messages back from their clinical teams, often quite appropriately, saying, I haven't seen a case like yours before, or I haven't treated this particular rare cancer before. And whilst many cancer patients are involved in multidisciplinary boards and have decisions made at that level, that doesn't necessarily mean that they feel that all of their decisions are being made in a way that is backed by sufficient expertise. So patients would become concerned and then would doctor shop and would end up, for example, at Rare Cancers Australia. And we got a lot of feedback about this sort of lack of security. And so often we were parts of expert email panels answering questions, and we can only imagine that that is not best practice. So a number of us, there were 10 of us who set about trying to design a program that would enable patients from anywhere in Australia to receive expert care. And although it went through several iterations, that is in fact what became the ARC portal. And so a patient can be referred from anywhere in Australia via their cancer specialist, so not by a GP, but it could be a surgeon, medical oncologist, radiation oncologist. And they can be referred virtually through the internet using our website, and there's a secure way of uploading data. We partner with BioGrid Australia so that data privacy and security is a very important part of our model. Patients all consent to a research study so that we have consent to hold their data and do things with it, and they can consent to optional biosamples collection and can be pivoted into research, which is also, I think, very important because lots of rare cancer patients don't have access to research. So then the process is that we look at the case, and depending on the questions asked by the doctor, we will provide guidelines. If there are no guidelines, which for many of the patients referred to us there aren't, we'll provide best evidence from the literature. If there are specific questions requiring it, we will go to national experts and international experts. And we haven't ever really had a situation where we couldn't find the appropriate expert one way or another. And in this setting, experts are usually very happy to contribute. We describe the fact that unlike certain setups overseas, for example, in the US, this is no one's getting paid for this. This is about giving doctors back advice so that patients can stay with their primary doctor. And I think once doctors understand that you're actually trying to keep patients with their doctor that's closest to home, that's obviously best for them, they realise we're not trying to shift patients in the system, we're actually trying to keep them in the system. And we always connect back with MDM opinions and maybe recommend a different MDM if we think that the correct MDM hasn't been chosen. So that all allows us to check the diagnosis, make sure the correct genomic testing's been done, provide information back about what the best treatments would be and ways to access the treatment. And so in that, we partner with Rare Cancers Australia to try to increase access, particularly to high-cost drugs. And we'll do that by going straight to the pharma companies that have the drugs required. And instead of a busy clinician having to make the argument, I've made lots of arguments to pharma companies over the last 10 years, and I know the most successful are quite long-winded, lots of references, and we do all that work. So our fellows will write the reports. A report is written for every patient we meet weekly to make sure that these reports are developed in the right way and approved before they go out. Often pharma companies like receiving those reports alongside the email that requests special drug access, because then all their work is done. They just have to check that they think we're right. We've never been told that we weren't, and we're often successful with getting access to drugs. When we're not, we partner with Rare Cancers Australia in helping a patient fundraise. So we'll provide the initial link to Rare Cancers Australia. We'll provide the professional opinion about what makes this case so special. And we know that when people give, they're most likely to give to an individual based on special features of the case. So we will help Rare Cancers Australia recognise what the key features are, and then I know they do amazing work, one-on-one with the patient in setting up that fundraising. The other thing, of course, we'll do is find the right clinical trial, and sometimes that will be an interstate trial, but we might find a very special one, and then again we can sort of help with access for patients to travel, and that's through Rare Cancers Australia as well. But sometimes it is a matter of finding a very boutique trial for some of these patients. And so we're better placed to do that than a busy clinician in a metropolitan or regional consulting room.
What an extraordinary partnership and genuinely life-changing for patients.
Yes, we can certainly give examples of that, and certainly have a lot of doctors who are re-referrers for that reason.
Well, Claire, thank you very much.
Great pleasure.